Hello friends, welcome so much to my YouTube channel, the Dr. Krishnan lecture. I am Dr. Krishnan, doing super specialization in neurology at Indraprastha Apollo Hospital, New Delhi. Do subscribe to my channel for more and regular updates on interesting topics of the medical science.
In this lecture video, I will discuss about an interesting case of paraplegia first reported from India. Let us start with a clinical case. A 45-year-old man born out of non-consanguineous parentage presented with progressive difficulty in walking for 3 years duration. Walking difficulty was due to a stiffness in both lower limbs. He had urinary urgency with incontinence for 1 year. There was no diurnal variations, stiffness in the upper limb, craniobulbar symptoms, sensory symptoms, incoordinations, seizures, and cognitive decline. His father had walking difficulty at the 7th decades and was diagnosed as a spastic paraparesis. There was no similar complaint in his sibling. Neurological examination showed normal cognitive, speech, and cranial nerves. Motor examination showed lower limbs power of 4/5. Assessment was hindered because of the spasticity and upper limb power of 5/5. The spasticity in both lower limbs, grade 2 according to modified Ellsworth scale, grade 4 deep tendon reflex in both lower limbs and grade 2 in the upper limbs. There was absent jaw jerk. Sensory examination showed impaired proprioceptions in the distal lower limbs, and there was no signs of incoordinations. Romberg's test was negative. Plantar response was extensive. Complete hemogram, renal, hepatic, thyroid functions was normal. Serological tests for HIV and syphilis were negative. Whole spines and brain magnetic resonance imaging showed mild cortical atrophy with no corpus callosal abnormalities or ear of larynx side. Cerebrospinal fluid was normal. Somatosensory evoke potential for median nerve and tibial nerve showed normal cortical potentials. Nerve conduction studies were normal. Whole exome sequencing showed missense variants of, that is OSCE5 at exon 16 in the OSCE5 gene. So, what is zone diagnosis? Also called as familial spastic paraplegia, was initially referred to as the Strumpel-Lorentz disease, a name given by two physicians who in late 19th century independently described the key features of spastic paraplegia. Hereditary spastic paraplegia are groups of genetically and clinically heterogeneous group of inherited neurodegenerative disorders characterized by length-dependent retrograde corticospinal tract degenerations. They can be classified as pure and complicated HSPs. Pure HSPs have lower limb spasticity without prominent additional clinical findings other than mild urinary symptoms and impaired distal vibratory sensations. Whereas complicated HSP are associated with neuropathy, seizures, cognitive decline, Parkinsonism, dystonia, weakness, and amyotrophy. The OSCE5 gene mutated in HSP8 in code for astrompelin, which is a member of multi-protein Wiskott-Aldrich syndrome's protein and SCR homologs. Complexes are involved in endosomal shortening. Astrompelin has N and C terminals with intervening spectrin repeat domain. Mutations in the spectrin repeats domain hampers the interaction of astrompelin with other proteins, and thus endosomal fusion defects result in pathogenesis of HSP8 mutations. So, the differential diagnosis for HSP include amyotrophic lateral sclerosis, adrenomyeloneuropathy, acquired diseases like tropical spastic paraplegia caused by human T-cell lymphotrophic virus 1 infections, vitamin B12 deficiency, multiple sclerosis, cervical myelopathy, hereditary ataxia with significant spasticity like ataxia, metabolic disorders like methylene tetrahydrofolate reductase deficiency and cobalamin C deficiency, arginase deficiency and urea cycle defects, phenylketonuria, glycine encephalopathy, and cerebrotendinous xanthomatosis, as well as Sjogren-Larsen syndrome. So let us start with it. So again come to the case that we have discussed in the beginning. This 45-year-old man, born out of non-consanguineous parentage, presented with progressive difficulty in walking for 3 years duration. The walking difficulty was due to a stiffness in both lower limbs. He had urinary urgency with incontinence for 3 years. There was no diurnal variations, the stiffness in the upper limb, craniovalvular symptoms, sensory symptoms, incoordination, seizures, and cognitive decline. His father has walking difficulty at the 7th decades and was diagnosed as spastic paraplegia. There was no single complaint in the sibling. So, applying the criteria for HSP8, the clinical findings include onset in the age of 20 to 30s with the range of 20 to 60 years, slowly progressive pure spastic paraplegia of lower limbs, that is pyramidal signs include hyperreflexia, spasticity, and occasionally clonus, without other neurological findings, and distal decreased vibratory sensations. So, applying these patients these patients had also urinary symptoms, and this all fits into clinical criteria for HSP8. Family history include autosomal dominant inheritance, that is affects male and females in multiple generations. So, applying the clinical criteria of HSP8, this patient fits into it, and absence of known family history. Neurological examination show normal cognitive, speech, cranial nerves. Motor examination showed lower limb power of 4/5. Assessment was hindered because of the spasticity. Upper limb power of 5/5. The spasticity in both lower limbs. Grade 2 according to modified Asperger scale, and grade 4 deep tendon reflex on lower limbs, and grade 2 in the upper limbs. Absence of jaws. Sensory examination showed impaired proprioception in the distal lower limbs and with no signs of incoordinations. Rumble test was negative, lateral response were extensors. So, applying the criteria for HSPH, sensory examination showed impaired proprioception in the distal lower limbs with no signs of incoordinations and rumble test negative, lateral response are extensors. And slowly progressive pure spastic paraplegia of the lower limbs, that is pyramidal sign, include hyperreflexia, spasticity with occasionally clonus without other neurological findings. These are the criteria for HSPH. Along with mild distal decreased vibration sensations. Further, our patient has the test for complete hemogram, renal, hepatic, thyroid functions were normal. Serological testing for HIV and syphilis were negative. Whole spine brain MRI showed mild particle atrophy with no corpus callosal abnormalities or ear of lilac side. Cerebrospinal fluids were normal. Somatosensory potential for median nerve by tibial nerves showed normal particle potentials with NCB were normal. Along with whole exome sequencing showed missense variant of OSCE5 at episode 16 in the OSCE5 case. Again, applying the criteria for HSPH, the neuroimaging findings in the patient include brain MRI is generally normal. In one moderately affected individual, spinal MRI showed significant atrophy of the thoracic spinal cord as determined by cross-sectional area. Other studies are normal as cerebrospinal fluids, electrophysiological studies, LCVs, electromyography, biochemical testings, vitamin B12 deficiency, very long-chain fatty acids and lactates, family history. For the criteria include consistent with autosomal dominant inheritance with affected male and females in multiple generations. So, on applying the criteria for paraplegia, contain pure autosomal variants. And this patient was started on oral baclofen for spasticity and difenosin for spastic bladder symptoms. Thank you. With this, I will end up my today lecture.
Thank you so much for your kind attention and watching my lecture. I will end up my today lecture with a beautiful quote defining success. That is, define success on your own term, achieve it by your own rules, and build a life you are proud to live. With this, I will end up my today lecture. Thank you all.